Yeah, sure.
Sir, are we ready to go live?
Yes, thank you.
Okay. Yeah.
We are
So,
live in
good
we are
morning.
live in 5, 4, 3, 2.
So, good morning, everyone. And in today's Fellows Teaching program, we are going to discuss a neglected pediatric femoral neck fracture, which is a real problem situation. And for that, we have very senior faculty, Dr. John Mukhopadhyay, to take us all through this entity. I would invite Dr. Sheenam Bansal to take over and introduce the faculty and start the program. Sheenam, please.
Yes, sir. Hello, everyone. Thanks for joining. Today we have Dr. John Upadhyay, sir, is with us to talk about neglected femoral fractures in children. It's my privilege to introduce Sir. Dr. John Upadhyay, sir, is one of the leading orthopedic surgeons in East region of India. He has enormous experience of many years. He has been chairman of Orthopedics Research and Education Foundation India, Indian Orthopedic Association Trauma Committee. He has been faculty at various national and international courses and meetings. Sir, can we start?
Yeah, sure. So thanks, Maulin and Sheenam. I'll get started sharing my screen, and we are going to discuss neglected neck of femur fractures and basically concentrate more on non-unions than other things, although there are other complications of neck femur. So if you look at any paper, they talk about 1% being the incidence of neck femur fractures amongst pediatric fractures, but we don't have statistics from our own country, and it's probably a bit higher if we look at it overall, because we do see a reasonable number of them. But the bigger problem is that they have a higher frequency of complications, as was mentioned by Terry Canale. Now, if you look at non-unions, again, from the literature, it's around 7%. But if we look at our Indian figures, unfortunately, we don't have them. A lot of the ones which probably would be treated with operative fixation with screws don't get so in our country. And so we do see a lot more of the non-unions than probably what is available in the Western literature. Even if they are fixed, they're often fixed in an unreduced position, or there's some disturbance from somewhere. Yeah, either they are unreduced or they are fixed with inadequate fixation. Okay, so if you have just two thin screws, sometimes in an older child, that's not adequate fixation, and it's likely to fail and then drift into varus or fail altogether. So it's not uncommon that we see situations like this coming to us, where patients either have been treated non-operatively, completely neglected, or even when surgery has been done, it's been inadequate. And a lot of problems are related to that, unfortunately. Now, the diagnosis is essentially based on clinical findings and x-rays. You need to get good quality radiographs. Occasionally, you have a situation where you may need a CT to make out a non-union. For example, in a situation like this, you would sometimes need a CT to make sure that it's a non-union and not a malunion, or so a CT would sometimes clarify things for you, but always remember that CT tends to exaggerate non-unions. Now, the treatment would depend on a few factors, like how old the fracture is, the site of the fracture, how much displacement is, whether there's neck absorption or not, and of course the age. So you can't expect the same treatment for a patient presenting to you above, where the position looks good and it's just a non-healing fracture. Well, in the other one, it's probably happened at a very young age with a lot of displacement, trochanteric overgrowth, etc. So different situations would need slightly different plans of management. And if we look at the options that we have, they range from internal fixation. I think valgus osteotomy probably in our hands is the backbone of most of our non-union treatment. Fibula graft has a role in certain situations. We don't tend to use it very often, as are other forms of graftings, the muscle pedicle graft and even vascularized graft. But we don't seem to use that very often in our setup. And then you have the salvage procedures such as McMurray's. You can do sort of excision of the head and a pelvic support or a pelvic support osteotomy on its own, which has a role in certain situations. So when it comes to internal fixation only, it's very rarely that they come to us in a situation like this. This was a 15-year-old who came to us 3 months after the injury. And when we put him on the traction table, everything looked reduced. So we just went ahead and fixed it. We didn't do an osteotomy in this situation. And as you can see in the follow-ups, this is 6 months. It took some time for the fracture line to disappear altogether. At 2 years, we were a bit worried that he may have AVN, or he does have some AVN, and what would it progress to? Luckily, it went on to heal. This was him at 4 years post-op. You can see there's a bit of collapse because with the screws having backed out. But this is him at 7 years. He's still functioning well. It hasn't collapsed any further. It's gone on to heal. And he's got a fairly good function with maybe a very minimal shortening on the left side. Valgus osteotomy really forms the backbone of treatment of non-unions. And this is based on Powell's concept. The idea is that when you have a steep angle of the fracture, there's more shear. And by reducing this angle to a more horizontal angle, you reduce the shear and you convert the shear forces into compression forces. Okay, the shear with this wedge osteotomy gets converted to compression forces, and this will then allow the fracture to heal. How much we do, etc., will depend on what you're trying to achieve an angle of. And usually you want to convert a 3 to a 1. By and large, these are not often very exact measurements, and we tend to try and get a reasonable angle. Take a wedge of around 30 degrees would be the average kind of wedge we take in the really old cases. So here's a 12-year-old girl, and there are different ways of fixing them as well. So you could use an angle blade plate, you could use a DHS, and today you have the special plates, the pediatric hip plates, which you can use, which allow you to lateralize at the same time. This is a 12-year-old girl who we treated with a valgus osteotomy with a DHS. You can see how the vertical angle here is now converted to a horizontal angle. There's some lateralization with the DHS, but that lateralization can change because the DHS will allow some collapse on this side, so that lateralization may not stay. And you can see how this has gone on to heal well. This is at 4 months post-op, and this is at removal of implants 27 months post-op. It's still a nice spherical head, which has gone on to heal well. This is older child, basal fracture, fall from height, and this was fixed with a DHS. And if you probably look at it, it looks okay, but you can't always tell what's happening here. So you don't know whether the screw has been locked in a way that doesn't allow collapse. It's a short barrel plate for a long screw, and that doesn't always give you the best biomechanics. And you can see how this has collapsed into varus. And he presented to us at 9 months with having difficulty in walking and pain. And you can see how gradually the fracture has been drifting into varus. And you can see that the fracture has not healed either. And so here we used an angle blade plate. We did a valgus osteotomy. Again, you can see how the fracture sort of geometry gets changed with the osteotomy. This is him at 4 months. You can see how it's gone on to heal. You can see the long leg axis is good, and this is him at 7 months. And this is his function. He's walking well. He's able to sit, squat, and gait is also pretty good. He's able to run, and he's doing quite well. So I think the valgus osteotomy really is the backbone of treatment. As I mentioned today, we have these pediatric hip plates. These allow you to actually lateralize with the osteotomy so that you can maintain the true mechanical axis. So here's a young child who was treated conservatively in a cast. That was the position when the cast was removed. And when she came to us, you can see she's drifted further into varus. This was about this time, about 7 months since her injury. And again, the CT clearly shows the non-union, as you can see here. And so here we use this plate, the pediatric hip plate. You can see how much lateralization this has given us. But there's a reason for that, because as you see the follow-up, you can see both the osteotomy and the fracture going to heal. Again, this is well healed at about a year and a half. And if you now then look at the mechanical axis, it goes through the center of the hip, center of knee to the center of ankle. So the idea of the lateralization of the distal fragment when you do your osteotomy is to get the mechanical axis right. Having said that, it's not always possible or practical to do it. And there are situations where you would even medialize to get a better support for the neck, but those are unusual, okay? So this is her function. You can see gait as well, and that works. Okay, don't worry about that. So here's a situation where we got a patient late, where someone had done a fibular graft and a screw. Now, this is unfortunately could be a proper method of treating it if the reduction had been right and the placement of the screw and the graft had been right. But unfortunately, this is what he came to us with about 6 months after the treatment. He also had what looked like possibly low-grade infection because he had a very stiff hip. So we weren't sure what was going on. When we went in, there was granulation tissue, but not frank pus. So what we did here was we took out the screw. We just cut off the fibula, the outer part of the fibula, whatever was outside the bone, we just excised that and left the bit in the head there. Okay, and then we used this locking plate with screws across, left the fibular graft there. But you can see a big gap here. And this was the osteotomy. This was before the pediatric plates were available. This was a younger child, and we could have used a pediatric DHS, but we used this plate because we thought the locking plate would have some advantages. And it progressed sort of okay in terms of the healing, but he was still very stiff at about 1 year. And I was wondering what's happening here. And luckily, over a period of time, you can see how he gradually lost his stiffness, got back his movement. Fractures healed well. There's no evidence of any avian. And this is again at 4 years post-op. And this is when we took out the implants. And I think 1 or 2 of the screws broke, but he did well otherwise. Okay. Now, another sort of difficult situation. Now, here is a situation where there's a huge trochanteric overgrowth plus total absorption of the neck. Okay, so here we were trying to figure out what to do for this. And if you look at Powell, interestingly, he talked about another type of osteotomy, which was called the Y osteotomy. So if you had a situation like that and you did the standard wedge osteotomy, you would have very little support for the head. Okay, so you see this situation if you did a standard wedge osteotomy. So what he proposed for this kind of situation was to do a Y osteotomy and then medialize this fragment under the head. That's why I said sometimes you may have to do medialization to improve the support of the head. And so this is what was the proposal, that you convert the shear into compression, but you also get more support for the head by bringing the shaft under the head. Okay, so this is the Powell's Y osteotomy. So we can try to improvise on that with a simple locking plate, and we did this. And he went on to do what looked quite well, in the sense over a period of time, his function was good, but his lurch was quite a lot. So we decided at this stage to try and further distalize the trochanter so that we could improve his abductor mechanics. So that's what we did. We kind of brought it down and further increased the valgus a bit. And this was him. Now, almost at 4 years since the original fracture. He's walking well, good function, obviously a little bit of a shortening on that side, but considering the kind of situation he came in, he was doing quite well. And this is him 6 years post-op, still maintaining that and doing well. So here the idea was to get valgusization, but also then distalize. And maybe we should have thought of it during the first surgery itself, but we didn't think of it at that stage. Okay, this is another patient. This is interesting because this came to us very late, and you can see gradually. So I'll go back to the first. This was the original X-ray. That was what was done. You can see how it's going into collapse, and she had a lot of pain and was unable to walk properly. So what we did here was we did a valgus osteotomy. This was avian. They were still non-union. So we decided to do this valgus osteotomy using the hip plate. Again, if you see, we are able to lateralize it nicely here, get the right fixation. The plate is positioned okay. So I think these ones, your technical details also become important because positioning of everything should be right. Okay, so this is her at 3 years, 5 months post-op. Let me see if the video works here. Okay, I think there's another one later on, so we'll see that. Okay, and then finally we come to salvage in situations like this, where really she had some kind of infection. You can see the head is fused, and this is what he came to us with. And here we did a pelvic support osteotomy, and he got back quite a good function with that, was able to mobilize, get a reasonable function. Obviously, you don't expect a totally normal function at this. And McMurray's osteotomy is another method which has become kind of obsolete, but still has a role. And I think Professor A.K. Gupta from Kanpur had written up a fairly large series of it. I couldn't find the reference for that, unfortunately, but I'm not sure which journal it was in. But I remember this being talked about in various meetings. And so this is what we did. Of course, you need to keep the child in a hip spica after this, which we do anyway for younger children. And this is how it went on to heal nicely. So I think the McMurray's osteotomy, although sort of more or less obsolete in most textbooks by now, still has a role in certain difficult situations. Okay, just come to a couple of challenging cases at the end. This is a 13-year-old boy who presented to us 4 months after injury. Okay, and this is like a injury where the trochanter is off, the neck is off, and was really difficult to understand. So this was the original X-ray that he had. And then over a period of time, he had developed into that. And this is the CT. You can see how the shaft is completely away from the neck, and the trochanter is completely off as well. So what we did was we did an open reduction. We kind of got the trochanter back. We fixed the neck. And at the end of it, I was not sure how he would do. In follow-ups, as you can see in the X-rays, wasn't looking great, but functionally he was much better off. You can see how he's able to squat. He was able to walk. That's his gait. This is at 18 months post-op, so a lot better than what he came to us with. And then when we took out the implant, it didn't look so bad. I think the implant was hiding some of the situation, but although he's still a bit short and maybe a little bit embarrassed, but that can be corrected easily at a later stage. But we were able to get his fracture to unite well in a reasonably good position that he could function. Okay, so this is from an article which was a current concepts article in JBJS a few years ago, written up by people, by many Indian authors, including Sandeep Patwardhan, Taral Nagar, Premal Naik, etc. And the first author was someone called Sanghavi. And there's some useful, these were the key points of that article. saying that the most common cause of non-unions and femoral neck fractures in developed countries is failure of fixation or loss of reduction. Whereas in developing countries, it's delayed presentation. So we have both a bit of delayed presentation as well as poor fixation, which has failed. Most of the failures of fixation, if identified, retain adequate bone contact, hence removal of the offending implant, refixation without bone grafting, and valgus osteotomy to correct the biomechanical forces would work well. However, they said that those where there was a lot of intervening fibrous tissue, etc., you would have to put in some graft as well, such as a fibular stud graft. This is interesting and can be argued. There are many articles which talk about just valgus osteotomy, which seems to work. But I think there would be situations where adding bone graft may not be a bad idea. So this one case where we had a type 1 fracture coming to us, not very late, but about 6 days after the original injury. She had fallen off 3 floors. I think she was about 1 year, 3 months or 4 months old. And the initial X-ray that they had done was just an AP, which they missed in. But by the time she came, they did another X-ray with an AP and lateral, and you can see the gross displacement of a type 1 fracture. You can see the position, the attitude of the limb with gross shortening, external rotation. And interestingly, when we did the surgery, we did an open reduction. And when you did the capsulotomy, you can see even after 6 or 7 days, how much fluid is under tension within the joint. What we did was a very gentle open reduction, nibbling out the little bit of callus that was forming using a ronger. So we used the ronger to just nibble out the callus which was there anteriorly, and then with just gentle internal reduction, we could internal rotation, we could reduce the fracture. We put in 2 KVAs. Those were the KVAs we put in. Obviously, she was put in a hip spica. And interestingly, as you can see her follow-up, you can see how the the physis continues to provide growth. The KVAs are coming out, and she went on to heal well. So we have a 2-year follow-up on her with no evidence of facial arrest. This is the case which I've shown already. Let's see if the video works here. It's walking reasonably well at this stage. Not great, but considering the situation she came in, she's doing quite well. So in summary, I think neck femur fractures in children are relatively uncommon. Non-unions are not uncommon. Okay, so unfortunately, even though the incidence of these fractures may not be that common, the rate of non-unions is pretty high. I think you need to assess these carefully and plan, and then decide on your course of management. Okay, so have a clear idea that one thing you do need to correct is the very steep angle, because if you leave it in that angle, the stresses are high and it is unlikely to heal. So the valgus osteotomy is really the key to success in the treatment. You may or may not add bone graft depending on the situation. And some of these cases you can think of relative length, neck lengthening and distalization of the trochanter to improve your abductor mechanics along with it. So I think I'll stop there and we'll take questions. And
yes, so John, that was great presentation and the lot of experience. Now, I have also seen since the inception of this valgus plates, before that, I used to medialize the distal fragment a little bit in attempt to support the neck.
exactly, yeah.
And all this DHS or the other implants, they did not
lateralization.
I never found that the mechanical access issue. The thing with these proximal femoral locking plate is you need a very precise planning.
Absolutely, yeah.
Times the plate is touching the proximal side, it's just touching the screws, and all the screws are off. So for a novice, it's scary that whether it will hold it well or not. So how much is critical, That's my question.
So the answer to that is it's really hard to tell. I think the problems will not come in the short term. It will come in the long term.
Mm-hmm.
So if you do medialize and then you actually check the mechanical axis, there's going to be a valgus effect on the knee. And over a period of time, they may develop problems. I don't think they will all develop problems. I'm sure we've done things like McMurray's and patients are doing well 10 years to 15 years down the line. But this is part of the thing that when people talk about in the lower limb is to try and make sure the mechanical axis is correct. So yes, but sometimes the amount of lateralization you get is almost scaring in these plates.
Yeah.
Okay, you do it and then suddenly you're finding there's very little contact. So sometimes I actually reduce the lateralization so that I at least have good contact between the distal fragment and the proximal fragment.
And once the
I
fracture
don't think
heals,
it's an ideal plate. The
Yeah.
second thing is, ideally, I think you should have compression in the screws that go across the fracture. This
Yeah.
has locking screws in it. So there are some things about it which could be improved, but that's what we have at the moment. I'm sure.
Yeah, that's right.
So I sometimes use conventional screws as a first screw. So I compress across the fracture and then put the long ones.
Yeah, that's also we also do.
Yeah.
We just put one screw out of the plate, compress it, and then
put the plate.
yeah, because once it remodels, it remodels so well. A little bit of medialization.
Yeah, I think so. That's what I think in children. I don't know if anyone has really studied these in the long term.
Yeah.
What happens, because I think getting union is probably the most important thing.
Yeah.
And if you, in some of these where the neck is absorbed, like I showed there, you actually may need to medialize to get support, or you'll have to use something like a fibula graft to kind of maintain the length.
Right. Right. So we will share with all the fellows a technique of how to do the valgus osteotomy with the valgus AO plate, and we have some prototype plates also. Or if you have a video, then you can share it with us, and we'll share with the fellows.
Okay, for me.
Yeah, if you have.
No, I don't unfortunately have a video, but they have one for in the AO. They have the steps quite neatly out in the
described. Yeah, okay.
Yeah.
So we'll share that literature with. Fine. Any other question from anyone?
Yeah.
So we have one question from Dr. Meet. Any role of 3D printing here?
So I think you can never say there's no role of it, but is it really necessary? I think you get it's something which you need to look at, because I think with time we'll be doing 3D printings of everything as it becomes easier to do. Just like CT scans for fractures. At one time we never really bothered to do CT, and now for almost every intra-articular fracture we are doing CTs, and then even for some extra-articular fractures we think CT is necessary. So it's a matter of time, but I think you can get a very good idea from, if you have good 3D reconstruction, you can get a very good idea of the anatomy. So yes, I can never say 3D printing is not a good idea, but is it really necessary? And it depends on the cost and the delay involved in doing it. So if you have a very convenient availability of it, then do it.
So we have, John, we have started doing it for few very, multiple times treated and kind of congenital coxa vara.
Yeah, so that's the difference.
Yeah, where the deformity is in some central plane, not a pure coronolar sagittal.
Yeah,
it's there. As you say, it gives a very good idea that where we are, and the key is to put the screws well in center. And so now we are coming up with some zigs, pre-operative zigs. Yeah, and then you operate first on that model.
A few places, I think a few places are working on that, and I'm sure. But personally, I think it's a lot of this can be done if you have a good idea of the 3D anatomy. But yes, certainly it would help, especially for learners and people who are sort of setting out to do these difficult situations, I think it's definitely of help. And we also sometimes struggle with these. So any additional imaging that gives you some more knowledge of what's happening is always a good thing. And then if you have jigs which help you with the cut and they work well, certainly those are good. But you must still have your own, whenever it's like robotic surgery, it would definitely help in some ways, but if the person controlling the robot goes haywire, then everything is going to go haywire.
So Taral has a bit of experience in this, and he said sometimes it happens so that you just take over.
Yeah.
The jigs also may not place the things, and you
You
do
have
by
to then readjust.
Yeah.
So you should not rely entirely on this and not forget your clinical assessment altogether.
As we may not have used questions, how do you appeal these fellows to how to read X-ray? I think that reading X-ray to make decision is the most key point. So we just narrate there, and then we'll go for case presentation.
Pardon?
Yeah. How would you suggest young trainees to read a neck non-union X-ray, which helps in decision making? Just the summary of your talk.
Okay. So I think the first is to decide on the non-union. Okay. So I think usually it is pretty obvious on X-rays. When the fracture is not united, the X-ray will show you either a gap or a persistent fracture line. If it's displaced, it's obvious altogether. So there are very few situations where you might need a CT for a diagnosis. What you need to look for in the X-rays is, one is the head viable or not? But in a small child, that is not going to change your management. You're still not going to sacrifice the head. You're going to try to get healing. The second one is the gap, size of the head, the gap in the fracture. Because if you have a huge gap, then you might have to think of methods to fill that gap with graft or whatever. And then the angle of the fracture, because anything that is vertical is going to be causing a lot of shear stresses. And the moment, it's amazing how these heal once you just change the angle. Because I've seen them without even fixation, where just because you've done a valgus osteotomy and converted the angle, even if the fixation is not so great, they seem to go on to heal. So I think those are the few things that you really need to look at. Position of the trochanter. Now there are techniques, I think, Molin, you must be doing that relative neck lengthening and
that's
so that's another thing which is new with, and you can distalize the trochanter where it's gone up, and those things which are relatively new but very useful in certain situations. But you have to watch that carefully. So when you do a valgus osteotomy, anyway, the trochanter comes down a bit. But if there's overgrowth, then you need to get the trochanter down to really, you can't correct all of that with just the valgus osteotomy.
We don't do those things together. We just stage and primarily focus on healing of the fracture. And then in second stage.
I think that's the more, in some ways, a practical way of doing it.
Yeah, that's right. So that was an experienced summary, what John said, and thanks, John, for that lovely talk.
No, sure, thanks.
So shall we move on to the case presentation?
Yeah, sure.
Deepak?
Yes, sir.
Deepak, you can share your screen. Yes. So Dr. Deepak Khurana is from Jaipur.
Okay.
He's a consultant pediatric orthopedic surgeon.
Right.
Am I audible?
Yes.
So thank you, Dr. Mollin, sir, for giving me the opportunity to present. Myself, Dr. Deepak, I'm practicing as a pediatric orthopedic surgeon in Jaipur. So I will
Deepak,
start
you want
with
to make it full screen? Can you make a full screen?
Yes, sir. Yeah. Okay.
Yeah.
So my case is a girl. She presented with a painful limp on the left side. There was a history of fall, which was treated with quack with no X-ray was done. And at presentation, there was a flexion deformity of 20 degree. Both AISS was on the same level. There was painful rotation on jaw movements. SLR was weak as compared to the contralateral side, and there was a significant true shortening, subtrochanteric true shortening. So we got this X-ray. So there was a with migration with some resorption. There was a vertical fracture line. Version looks okay in this X-ray. So question which are needed to be answered before starting treatment in such cases is whether there is any need for MRI, what is the role of close reduction, what is the need for open reduction, in situ fixation, type of implant, need of vascularized fibula, non-vascularized fibula, role of valgus osteotomy, and pre-operative planning. So I'll be talking more on pre-operative planning and tricks for fixation in these type of cases.
So
that
before Deepak, can you go back to the slide and yeah. So let us discuss this X-ray and then we'll
Yes,
know what you have done. So John, how would you read this X-ray? As far as this management part is concerned, besides what Deepak has mentioned. John.
Yeah, so this is obviously a subcapital fracture with a non-union vertical fracture line as fixed on this position. But obviously you need to assess that on the table. There's some absorption of the neck when you compare it to the opposite side for sure. And so one of the things you need to always rule out in these is it a pathological fracture or not? Because it could have fractured through a cyst in the first occasion. Something you need to always look out for, which I didn't probably mention, but but the treatment doesn't change too much. Even if it was through a cyst, you would probably still do the same in terms of the treatment. So for me, this would be like a valgus osteotomy. I mean, get it down. I think interestingly, all these very displaced ones, once you put them on the table and put traction on them, they come to a reasonable position. So rarely, I mean, we do open reduction in some of them, but it's unusual for these subcapital ones to need open reduction.
Yeah, so I agree with you. There is a sclerotic margin of the proximal fragment. So it shows that there's little older injury. And at times I've done this, if the child allows a varus and valgus X-ray to see whether this thing moves together or not. And under image intensifier, when child is asleep, that you can see. And if the things are moving in situ, then it's not wrong if you just fix the fragment in situ with a extra the screw going outside the plate, and then do valgus as John said. Fine, Deepak, this is our observation that pathological fracture, we can see some lucency in the distal fragment. So path fracture is a but as it might not change the plan. Yeah. So please show us how you plan.
last question. One, I want to ask one question.
Yeah, please go ahead.
Is there any role of taking out the reamings for biopsy?
So, I mean, this seems to, if at all, we think that this is a lesion and we see the common cysts are there. This is a long-standing X-ray, so this does not look like a benign aggressive lesion, you know. And to take a biopsy.
If we are thinking, so is there any role like you?
So, to take a biopsy, you know, we need not open this to take a biopsy.
No, so through the rimming of that.
Through the rimming you can take, but I'm not sure whether
Yeah,
that
I mean, you can send it just to be sure that it's nothing more sinister, but it's unlikely to give you a very, maybe if you are suspecting malignancy, but here if you look at the margins, it's
sclerotic.
Sort of sclerotic, and if it was malignant, it would have already spread outside the bone by now. So I don't know if
the only one thing which is there is a kind of we have seen some neurofibromas, but again the key thing is if for this small cyst we don't graft. If it's a huge cyst, then we will open anteriorly and put some graft there. So I think you go ahead with just in considering this is a simple neck femur non-union.
So there are multiple papers. I will also recommend to read this paper which Dr. John recommended, the current concept review of non-union in pediatric neck femur, presented from Sancheti Institute. So they concentrated on the causes, and one causes was improper fixation, the other was delayed presentation. So for delayed presentation, we should evaluate for neck resorption, reduction, and interposed soft tissue pathological causes, as we have discussed. And the treatment method can be an in situ fixation, neck reconstruction with fibula if the defect is there, especially inferomedially, plus valgus osteotomy. So as per them also, there is no role of any pre-operative MRI, gentle close reduction if possible, in situ fixation with valgus osteotomy to improve the biomechanics, and fibula in the cases when there is an resorbed inferomedial neck. So the ideal implant for valgus osteotomy in my practice, I generally use single angle implant like a DHS or a locking plate or a blade plate. These type of implants are important because like they correct the deformity at the level of the cora. And since we are not doing the osteotomy at the level of the cora, we are doing it distally. So to avoid any secondary translational deformity, these fixed angle implants are very important. So what are the advantages? Since the correction with this fixed angle implant is precise and implant driven with a proper pre-operative planning, it follows the osteotomy rules. They have better lateral translation of the distal fragment and maintain the neck length. There is no need to take out any wedges, especially in smaller degrees of correction. They equalize the limb length discrepancy to the maximum extent. So I will discuss the pre-operative planning. So we can plan these type of cases with two methods, either with the difference in the neck shaft angle or through the pulse angle. There is an important thing which should be considered in the pre-operative planning is this first pin or a pre-operative, this line should be drawn connecting the top of the GT to the center of the head, because many a times it is become difficult, especially for the early trainees, to identify the neck axis or the neck alignment. So by drawing a 45-degree angle to this line, we can get the neck. Like in this case, you can see, since the metaphyseal fragment is going up, so we actually can't define where the neck alignment is. So to take the proper angle for a pre-operative planning, you can do this by connecting a line center of the head and the top of the GT and making a 45-degree angle to consider it as a neck. So through that, the angle which I was able to calculate was 105 on this side and 135 on the other side. So the difference of the angle is now 30 degrees. And I take 5 degrees as an overcorrection. So the correction which I am planning for this case was 35 degrees. So now what depends is, since to make the surgery simple, pre-operative planning, just we have to put first guide wire in a proper position. So the projection of first guide wire is most important. So how to calculate that projection? So that projection will be the angle of implant, the fixed implant which we are using, like whether it can be a 30 degree, 130 degree, 140 or 150. It can be any which is available, minus the angle of correction. So in this case, I was using 130 degree of pediatric DHS and a 35-degree correction was needed. So my guide wire projection was 95 degrees. So plan was in situ fixation, close manipulation, 130-degree fixed angle pediatric DHS was used with CC screws and add on valgus osteotomy. So on intra, when I took the patient on traction table and close manipulation was done, and with some abduction and some internal rotation, I was able to get that metaphyseal fragment slightly below, and the angle which I was able to calculate was initially it was 105, but now because of that slight manipulation, it came out to be 20 degrees. So one point I want to suggest to the trainees is like we shouldn't be rigid with our pre-operative planning all the times, because many a times after taking the patient on traction table, scenarios changes, and we should be flexible to change our plan according to that. So like in this case, the correction angle now becomes only 20 degrees. So now the angle of guide pin also changes. Now it is 130 minus 20 equals to 110 degrees. So what I use a variable angle guide of a DHS, and I put that according to that guide pin angle. So it was 110. So I put two K wires or a guide wires parallel to each other in the neck, and the above wire was used and replaced with a CC screw, so that during the reaming of plus we can get a compression at the fracture site first of all, and second we avoid any turning of the head while reaming it for the DHS. So in this pic we can see I'm placing that plate of 130-degree DHS, and it's clearly showing a 20 degrees of offset, which will be used for correction of that angulation and lateral translation. So first the screw was passed and secured to the head during the reaming for the DHS. Osteotomy is marked distal to the lesser trochanter. So the important part is how distal you have to take the osteotomy. The more you take the distal osteotomy, lesser will be the contact. So it is important to take that osteotomy just 1.5 centimeter below to your Richard screw to avoid any interference with that screw stability. Since I'm doing a true angulation translation osteotomies, for a smaller degree of correction, no wedges are taken out. But for a larger degree, you have to take the wedges. After doing the osteotomy, we attach the plate to the Richard screw, and the traction is given, and distal fragment is taken to the plate, taking care only of rotation. The angulation and translation will be taken care of by the implants. Valgus and translation are automatically taken care of with a precise preoperative planning and the use of appropriate implant. Post-op lengths were also equal. Caution is there in high degree of correction, because in higher degree of correction with this method, you can get a lesser contact. So one option is to bone graft that particular open area, or the other option is to do a oblique osteotomy and take out a small wedge from the distal fragment, so that to get a full contact. But generally they heal very good. This is the immediate post-op. You can see there is a contact. If I would have taken a osteotomy bit proximal, the contact would have been more. But it doesn't matter much, because healing in kids are very good and they generally heal with this much of contact also. This is a 6-week follow-up post-op. There is a 3 months. Now you can see that gap has filled automatically. The mechanical axis is maintained, the neck length is maintained, even neck has united. This is a function. This is at 9-month follow-up. This is a walking video. She is walking without any limb discrepancy or any lurch. So from my side, take-home message is pre-operative MRI is not mandatory, and it does not changes the management plan. The radiographic evidence of AVN in presence of non-union is not a contraindication for reconstruction. Head revascularized once union is achieved and stop further collapse. You should avoid open reduction in delayed presentation. Valgus osteotomy in delayed or failed cases always a good option. Non-vascular fibula is a good option to cover the resorbed neck, especially inferomedial part. An implant-based correction always give a precise result without any secondary deformity. Thank you, sir.
Okay. So John, you want to add any planning thing? I asked Deepak to talk about bit of planning, so fellows could
Good,
learn.
because luckily I didn't put any of the planning in my talk.
Yeah, so there was no overlap, I think. Yeah.
Yeah, so I think, yes, planning is important if you, but the thing is you have to modify your plan once you put the patient on the table. That's important.
Yes, sir,
because
definitely.
pretty often that angle that you measure pre-op is not the angle that you see on once you put the patient on the table. The other thing is that the DHS can mislead you about lateralization, okay? Because the proximal fragment can collapse. And then what you find over a period of time, that it may not go back all the way, but you lose some of your lateralization by the time the fracture heals, okay? Because there is a little bit of gliding. So you can call it medialization or of the distal fragment or lateralization of the proximal fragment, but it never heals in exactly the same position as you have achieved at the end of surgery. Whether again that's significant is a matter we can it's of conjecture. Whether long term it really makes a difference to the knee joint is something we still really don't know.
And the other thing is your screw is going through the physis, and you have to be careful about limb length discrepancy, which you can deal with contralateral epiphyseal
Yeah, so
disease.
probably in an older child, it doesn't make any difference, but in a young child, you can't put a DHS through the physis because it's definitely going to cause growth arrest there.
Yeah.
Unless
So,
the fracture is very proximal, then you have no choice.
here the fracture was very proximal. So, yeah. So here, like when this such situation comes, that we focus on healing of the fracture rather than anything else. But the limb length discrepancy, we need to take care even after 1, 2, 3 years. We have to follow them. So that
But
was
when
a
you do
nice.
your valgus osteotomy, you get some lengthening anyway. So there are ways of trying to calculate how much length you get depending on your wedge. So you want more length, you don't make a complete wedge. If you want less length, you make a complete wedge. So depending on the shortening, you can adjust your wedges or not take any wedge at all and just do a medial opening osteotomy. So all that can be calculated on the table if you really want to beforehand.
Yeah, and many a times the post-operative X-ray, the femur looks crooked. So don't worry. What you need is a good valgus angle, and that will help.
Yeah, and then so that it looks like in valgus, the pelvis looks tilted very often in the first X-ray, but then it gradually will come back to normal.
So that was nice case, Deepak, and nice demonstration.
Yeah.
Do we have any other question? If not, then we will conclude this session. Thanks, John, for a lovely
Great.
talk.
Okay. No, thanks very much, Maulin. It was a pleasure. And excellent case, Deepak. Good. Great.
Thank you, sir. Thank you.
See you guys. Okay, bye.
See you next week with other session. I think that Dr. Ishwar is going to talk about femur fractures, and we'll discuss that. Thanks, John. Have a good time.
Bye-bye.
Thank you, sir.
Yeah. Bye. So, Meet, you can stop recording, and we'll upload it on our